here. And this talk is something I've done for patients, and part of the talk is for physicians. So it's a little bit of combination of both. So first disclosure, you know, I don't have any industry funding for anything I'm doing, but I think disclosures are important to have. I do have, in my time, I have done some work through with some of the different companies that have products in what we're talking about, but no funding for this particular talk we're going through. So this, again, a little bit about me. I've been in Orlando since 2000. I'm married, 3 kids. I have 2 dogs, 2 cats, a horse, and a rabbit. If anybody would like a rabbit, please contact me. I will ship ASAP. My interest growing up, I was a baseball player in college. I kind of now do some coaching, and I do triathlon and the like, but something just to keep busy and try to stay active with my wife and kids. In Orlando, so I got here in 2000. So I trained at the University of Miami for residency, and then did a fellowship for 2 years in Norfolk, Virginia, which was rebuilding all sorts of things, urethras, bladders, the like. When I got to Orlando, I did general urology and had interest also in cryotherapy. We did kidney transplants for 4 years, and I've done all that. But more recently, I've now focused on urologic reconstruction. And so we're now seeing mainly that here in my clinic, and we have a team that works together to help patients in that space. I did work for my first 18 years with the Prostate Cancer Support Group. We had Sherry Flint, who was our dietitian. So again, we took a lot of Mark's work and said, how do we make help men to get better after they've been treated with prostate cancer? A lot was diet. And these are a lot of the other topics we had, and some of those who've helped along the way. The bottom 3 of the talks that I did pretty routinely, and it would be erectile dysfunction, stress urinary incontinence, and I'd be open for any kind of question they had. And I found I often learned at these groups. That's why we like to do them. So let's talk about prostate cancer. You all know that there are many ways to treat prostate cancer. Many men are cured of their prostate cancer by any of the methods that we use for treatment. Certainly active surveillance is much more common than it used to be, but surgical with robotic prostatectomy, radiation therapy, cryotherapy, and HIFU are all, I think, effective treatments for prostate cancer. The real question is, what do we have after the treatment is done? What are the side effects that we're going to deal with? And so while we have high likelihood of cure, there are side effects that occur, and that's how do we make you better from those? So we look at some of the robotic prostatectomy data. We talk about the trifecta, like how are your outcomes? How do we measure those outcomes in real terms? Well, number 1, are you free of your cancer? Number 2, do you have erections if you had them before? And number 3, are you incontinent? And that's really the trifecta. If you expand that, a pentafect is, do you have no postoperative complications? You have negative surgical margins, which would again decrease your recurrence rates. And that's what I think those that do and treat the prostate cancer, which is what I don't. I'm not a surgeon. I'm not a radiation oncologist. I'm a urologist who does reconstructive surgery. But when patients come to me, this is what they're looking at: is, am I cured of my cancer, and do I have those side effects? And we look at what do we do in survivorship. We still follow PSAs, and we try to do rehabilitation for erections, and where are they with the other complications? And there are things that people are not familiar with. So when you look at things like Peyronie's disease, there's a higher incidence of affecting your erections with shape changes with Peyronie's disease following prostate cancer treatment. And we find that men have loss of penile length, size and girth, length and girth after their prostate cancer. And then a new thing that really wasn't described probably 10, 15 years ago, climacturia, the loss of urine with climax and foreplay incontinence. Things that men don't hear much about, but is occurring regularly after treatments. So we're going to try to work and kind of focus on stress incontinence as what Mark's asked me to go through today. So we'll focus a lot on that. So obviously stress incontinence, the involuntary loss of urine, occurs in stress maneuvers where cough, sneeze, movement, where you have urine that typically would not come out, you'll have loss of urine. Very significant issue for men that they deal with on a daily basis. There are different types of incontinence. There's sphincteric or stress incontinence, and that usually occurs after prostate surgery. There's urge incontinence, which is I have the urge to go to the bathroom. and the bladder squeezes or contracts and urine comes out. Much more common. That's what's most prevalent out there. But we're really going to focus on stress incontinence. There's overflow incontinence, which occurs when you're in tension, your bladder's overextended. And then there's a combination of all of the above. And this is a diagram kind of showing how each of these occur. But we're going to focus on really stress incontinence. To know what happens with stress incontinence, you know, how do we normally stay continent? It's pretty amazing that your bladder fills up and nothing leaks out. Well, what it is that has to happen is you have to have a bladder that is a stable bladder that allows the urine to fill up to a certain bladder fills to a certain volume at a low pressure. And that's what a stable, normal bladder is. So it expands up to, say, a volume of 300 to 500 cc's. And you don't get that feeling of I've got to go to the bathroom. That's that urge type component. And then you have a sphincter at the base of the bladder that helps to control and keep the urine in the bladder until it is time to urinate. And so when it's time to urinate, the sphincter will relax, the bladder squeezes, and then urine will pass out. And that's the normal pathway of urination and how we stay continent. And then if you look at this area, this is something we'll talk about when we look at surgical outcomes. Right in this area here, and hopefully you can see my arrow, this is the bladder cut away. This is the prostate, the shape right here. And then this right here is the sphincter. And the two areas that are important, this right here is the internal sphincter. That's kind of the normal sphincter you don't control. That just normally at rest will hold things closed. Down beyond the prostate and this end is the striated sphincter, the voluntary sphincter. That's what you do when you're doing your Kegel, squeezing open and closing that sphincter right in that area. And just to point out, the membranous urethra is that spot right there in the area of the striated sphincter or the voluntary sphincter. The length of that is important. You talk about outcomes, surgical outcomes, and continence. So just to give you the anatomy. So talking about continence and other prostate surgeries. So there's something we do called a TURP or a TURP. Some men will say I had a roto-rooter. So it's where you shave out the inner part of the prostate. I describe the prostate to men of urinary symptoms like a donut. There's the outer part, then the inner part. We urinate through the donut hole. As we get older, if the donut hole gets smaller, as the whole prostate gets bigger. So that's what happens as men get older. Prostate gets bigger, donut hole gets smaller, creates compression. Some men, they have benign disease and need to have relief of obstruction. One of the answers we have, which is the gold standard, is the TURP or the TURP. There are some other things out there, but this would be the standard. What we do is surgically go in and we shave out the tissue, and this is a little cartoon showing that. And when you treat BPH this way, there is a small incidence of incontinence. So the question is, what is the risk of urinary incontinence when someone has a TURP operation? And so when you look at what are the preoperative risk factors for incontinence when you have a TURP, a TURP for benign disease, if you're just a 55-year-old man, so like Mark and I, and we're going to have surgery having a TURP, the risk of incontinence is really 1 in 1,000, very low, not common. We discuss it with patients, but we don't expect many people to have incontinence following that. If you do that in an 85-year-old, the risk is probably more like 5%. So 1 in 20 are going to have incontinence. So it goes up. It's still relatively low, but it's 100% if you get it. So you want to know that information. And then if you take a patient who has Parkinson's disease, a neurologic condition that creates an unstable bladder that doesn't coordinate well, the risk of that is really about 25%. So 1 in 4 incontinent. So as urologists, we're taught, try not to do TURPs in a patient who has neurologic disease, specifically Parkinson's disease. So that's sort of a baseline of what we look at and say, what's the likelihood of incontinence after having a less invasive surgery like a TURP or a TURP? Now we're going to try to take that and look at what happens when we're going to have a bigger surgery, a radical prostatectomy. And again, when we're doing a TURP, if my arrow shows up here, hopefully for you, what we're trying to do, you can see my arrows, we're trying to shave this tissue right here to make that area bigger to allow the urine to pass through the space more easily. And again, we don't go beyond this little region right here, so we protect the sphincter to maintain control. So the sphincter is intact, the membranous urethra is intact, and that is not resected during TURP. When we do a radical prostatectomy, what we do is we come into the space and we would remove, we can do a bladder sparing procedure right here. We try to maintain the internal sphincter, the involuntary sphincter, and you take and remove the prostate, seminal vesicles, vas deferens, and try then maintain as much of the membranous urethra and the voluntary sphincter as possible. And that's what we're trying to do to keep and maintain. That's what the surgeons who do prostate surgery are trying to do. So let's talk about for those patients, and again, I know this is probably a different mix in the audience here. For those who are considering prostate cancer surgery, let's kind of go through something that might help you in making your decisions of what should I do with prostate cancer? Should I have surgery or not? So I'm going to try to break down some of the information we have. So there was a study done, a PLUS study in 2019, looking at patients considering prostate surgery. And what they found is that men who are older, and I don't, age is a relative number. It used to be if you're older than 72, that increased your risk. But I think some people are physiologically younger than that. But the older you are, the more likely you are to have issues with stress urinary incontinence postoperatively. Those who had a higher body mass index. So if you're a bit overweight, that may create an issue, though some studies refute that. Other studies show that is an issue. And then if you have preoperative urinary incontinence, that is also a risk factor having post-op urinary incontinence. Preoperatively, it may be urge type incontinence, usually not stress incontinence, but if you already have an unstable bladder, that predisposes you to have issues with incontinence post-operatively. So again, those three risk factors may lean you away from prostate cancer, prostate surgery, rather than going through a radical prostatectomy. We look at the anatomy. So for those who've had an MRI, they can determine your membranous urethral length. And studies have shown that if your membranous urethral length is greater than 12 millimeters, that you have an improved continence rate. So if you've had that, you could ask your surgeon, what's my membranous urethral length? And if they can identify that length, again, that may give you some valuable information to decide if you want to have prostate cancer surgery. So post-operatively, if we look at what are the risks you would have for stress urinary incontinence with prostate cancer treatment, looking at the membranous urethral length after you've had surgery can predict your likelihood of having incontinence and time to gaining continence. So if you have a prostatic or a membranous urethral length that is less than 14 millimeters, or you've had a decrease by 6% of the membranous urethral length, you'll have a slower time or a longer time to continence, and you'll have an overall lower continence rate if we find those post-operatively. So the bottom line is the greater or the longer your membranous urethral length is, the more likely you are to have continence following your radical prostatectomy. Some other things to look at. So again, you can look at, they look at studies looking at the shape of the bladder postoperatively. There's a ratio of how long the bladder looks like. They do what's called a cystogram, and they can identify how long it is versus how wide it is. And there is a ratio there that predicts continence. There's also how narrow is the bladder neck, how does it come down? And if the angle is appropriate, that's less than 100 degrees as it relates to the pelvic inlet on postoperative VCUG, which is a study they do after you've had your surgery, that can predict a better continence. And so there's some information that you can improve both of those parameters by how the surgery is done intraoperatively, by decreasing tension on the anastomosis, so that you have better recovery of your control. Okay, so what can you do? So if you're considering having prostate cancer surgery or prostate cancer treatment, frankly, what are things you do to improve your outcomes? One is know what your risk factors are. I think it's having an important, informed discussion with your urologist, the surgeon who's doing your surgery, your radiation oncologist. Figure out what are your risk factors that would predispose you to side effects after whatever treatment you choose. Improve your fitness and reduce your weight. Anything you do to improve your activity, improves your exercise, improve your diet. Any loss of weight will help you to recover and be more fit to recover after your procedures. Pelvic floor physical therapy. So for sure, anyone who has prostate cancer surgery should be doing this postoperatively. There may be some benefit doing it preoperatively. That may not be standard of care, but something you can look at to see if that would make an impact in your outcome. And then pick your urologist wisely. Without question, those who are more experienced doing the surgery have better outcomes. The number that they do varies. It may be that 100 is the right number to be significantly better than you were previously. It may be 200, but I think that the more commonly they do the surgery, they'll have better outcomes. I think that's true across the board, even in our specialty. When you look at things like artificial uterine sphincter or inflatable penile prosthesis, those who do more tend to do a better job. We're used to what are the issues, what are the complications, and the goal is to stay out of trouble and have the best outcome possible. Another thing your surgeon may do if they're more experienced, they may do nerve sparing surgery. And not only does that obviously help with erectile function, but there's some data showing that it may be helpful for continence as well. And so again, on top of that, if you preoperatively identify what your membranous urethral length is, and you find that it's greater than 12 millimeters, that may be, again, portend a better outcome for continence with a radical prostatectomy. So intraoperatively, if we look at what does the surgeon who does your surgery, what are the things that they would have to do to help with your outcomes, specifically as it relates to urinary incontinence, one would be nerve sparing. Again, there are two nerves. There's a right and a left nerve. Depending on your pathology, they may say we can spare one side or we can't spare either. That'd be a non-nerve sparing, or one side unilaterally, or if the pathology allows, can they spare both nerves? And there is some data showing that bilateral nerve sparing shows better outcomes as it relates to incontinence versus a unilateral or non-nerve sparing procedure. Second, they can do a bladder neck sparing reconstruction, just like we showed you there, where you can see you spare the internal involuntary sphincter so that you have better outcomes, and anatomically things are put together more reliably. There are some other adjunct maneuvers they can do to take tension off the anastomosis, some posterior reconstructions of the area, the Rocco stitch. But there are different things out there, again, to help with outcomes that are shown to make a difference. And then blood loss. If during your surgery you've had less than 400 cc's of blood loss, that shows a higher likelihood of having immediate continence. And we're not sure if that is because the surgeons have if they have more experience, they have less blood loss, so they have a better outcome because better technique, or there's some theory that maybe there's some regional ischemia because of that blood loss as they're doing the procedure. Do you have some issues where there's some issues with wound healing, and then you have the outcomes are not as ideal. So just some things you can look at as you're recovering from your surgery. What are things that may predispose you to better outcomes from continence? Okay, so this wanted to move over to something different. So we're talking about when someone's going to have, say, one type of treatment, which is surgery, or one type of treatment, which is radiation therapy. There are some patients, based on their pathology and based on their risk factors, they would do better with combined therapy. And some people get, 2 or 3 types of therapy. So some will have, for instance, a radical prostatectomy, and then afterwards they'll get radiation therapy, or the reverse. And so the question is, if you're going to get 2 therapies, does it make a difference in terms of the order for outcomes? And I would tell you, at least in my practice, what I see, and I usually see the patients after they've had their therapy, there's a big difference. And so I'm not sure it means one should be recommended over the other primarily, but I'm going to give you at least what our outcome is from a reconstructive urologist who treats incontinence and erectile dysfunction. So if we look at the first group, those who have a primary, first robotic-assisted laparoscopic prostatectomy, they have surgery first, and then they, for whatever reason, whether it's the PSA never goes down, they have positive margins, or the PSA comes back afterwards, they end up receiving adjuvant or salvage radiation therapy, which is they deliver radiation therapy to the area the prostate was. We find that men still do well from an incontinence standpoint. There's a minimal effect on urinary incontinence. There is some benefit for continence if you delay the radiation therapy till the patient is fully continent. And the incontinence rates are really a little bit higher, but not dramatically higher than what we'd have with those who just have a radical prostatectomy without any radiation therapy. So the incontinence rates are probably between 15 and 20%. The erectile dysfunction rates are more like 75 to 80%. If we look at doing the reverse, so say someone first has radiation therapy because they feel like that is the best therapy for them. And then they have a recurrence somewhere down the road because unfortunately the prostate's still in the body, the cells are still there, they still make a PSA, somewhere down the road, you have a recurrence of prostate cancer, you cannot receive radiation therapy again. Most typically, occasionally people have secondary radiation therapy. Those patients are oftentimes have significant complications. So really don't recommend that strongly. But even having surgery is dramatically more difficult after having a radiation therapy. The tissue just does not heal as well. What ends up happening is when you put stitches together, they don't hold as well. And ultimately, we can even tell when we look afterwards, has this person had radiation therapy first and then surgery, because the outcomes are different. So it's a much more challenging surgery for the surgeon who does it. We oftentimes find calcifications. Patients often have recurrent UTIs and strictures and stenosis, and the incontinence rates probably in the order of 50 up to 75% in some studies. And the erectile dysfunction rates are 100%. And when a patient's had this, it's really, you're trying to cure them. And, the side effects we can work on afterwards. But this is the more typical pattern that we see when you have therapy done in this way. So, all right. So irregardless of what surgery you've had, let's look at what happens when you have post-prostatectomy incontinence, stress urinary incontinence. The quality of life is significantly affected. This is one of the favorite things that I treat. You take men who are miserable with their incontinence. That is something that happens every day, 7 days a week. Whenever they're up and moving around, they are potentially wet. It affects everything that they do. And in an interesting study done, the British Journal of Cancer, they did a study looking at how distressing is stress urinary incontinence. It was much more distressing than erectile dysfunction, which we seem to talk more about as would be ED. In fact, patients were willing to give up over 2 years of their life to regain their continence again because it affected them so significantly, whereas they'd only give up 4 months of their survival to regain their erectile function. So men found that incontinence has a more profound effect on their quality of life after surgery. So let's look at what is the incidence of stress urinary incontinence. And these are high volume robotic surgeons. Like, these are the top numbers. Guys do the top number of cases in the world. And this is from 2009, looking at a review of these cases. And so 1 year following the robotic prostatectomy from the best of the best, the likelihood of having no pads and being fully continent 1 year is 84%. Another way of looking at it is it's 16% were still incontinent at 1 year. And then if you looked at and you kind of made that incontinence definition be a little bit less strict and say, okay, what if you just wore one pad kind of for if you had an accident, you coughed heavily and sneezed, 91% then would say, I just wear one pad or less a day. So it makes it a little bit better. But still, that means that 9% of men are still wearing more than 2 pads per day at a year. And these are from the high volume surgeons that are out there. So again, our stress urinary incontinence rate at 1 year, depending on how you quantify or qualify incontinence, would be anywhere from 9 to 16%. So it's a real number. If you're the patient who gets it, it's 100% for you. And that's what we'll work on. So now, say you're that patient, you've had surgery, and now you're now a year out from your radical prostatectomy, and you have erectile dysfunction, stress urinary incontinence. What is the probability of recovering your erectile function over time? So let's first look at urinary incontinence. So if at 1 year out, what's likely that another year down the road that you'll have urinary incontinence? Probably 30%. 36 months, 49%, 48 months, 59%. And those are probably favorable numbers, more so than you find in some other literature. Erectile function, sort of same thing. If you look out at a year, you don't have erectile function. What's it like? At about 2 years, it's 22%. 3 years, 32%. And then at 48 months, it's 40%. So I would say that the 1 year mark isn't kind of the cutoff. You got to make decisions there, but that's some of the data that's out there. Now, if you look at your urinary function versus the time from your radical prostatectomy, what is the likelihood for you to regain your continence? So the earlier you are after your surgery, the more likely you are to gain continence. So if we look at 1 month after your radical prostatectomy, 75% of patients who are incontinent will regain their continence over time. At 6 months, 58% will likely regain continence. At a year, still 41% will regain continence. And out at a year and a half, probably only 15% will regain continence. So the longer you go with incontinence, the more likely you are to continue to have incontinence, or the less likely you are to to obtain continence going forward. So I would say for us, that's really about the time we start to look at and say, what can we do for treatments? Now, how long should you wait before you have your incontinence treated? And so there is a recent study just came out last month looking at if you have stress urinary incontinence, if you wait, what happens over time? So say you waited 2 years, 3 years, 4 years, can you have treatment then and does it affect anything? So it's a Canadian study, like the men, average age 68. What they found is that over the time period of 4 years, 45% developed a new comorbidity. That is, they developed more diabetes, more hypertension, more coronary heart disease, and more arrhythmias. And what they ultimately found was that the duration of incontinence was associated with those new comorbidities. So the longer you waited, again, as we get older, you have more things that affect us medically, you're more likely to have those things occur. The age of the patient and the severity of incontinence were not related to developing new comorbidities, and there's no change in weight or BMI between prostate cancer surgery and incontinence, suggesting that really it was just the time and that it may have affected their ability to be active. So the idea would be we should have strategies to expedite the return of continence so that people can be more physically active, they can do more things, and likely minimize the risk of developing future comorbidities. So again, I don't think we have to wait years. I think at about a year would be a reasonable time to start to say, okay, where are we? Do we need to make any changes from a continence standpoint? That's what we're working on treating. So treatment options for stress urinary incontinence, we have observation, biofeedback, some clamps, bulking agents, ProAct, sling, and sphincter. We're going to talk through each of these a little bit. So first, observation. So no one has died from incontinence. No one has to have treatment. It's a choice. If you decide you want to live that way, you can. If you have a choice, if you want to have treatment, these treatments are all tend to be covered by insurances, and so there's no limitations there. And again, if you find the right people, you can have, I think, effective therapies to make your life better. But certainly, you can have observation. We would encourage pelvic floor training. There's some recently some guidelines were put out by the American Urologic Association. And SUFU is a Society for Urologic Female Surgery and Urologic Reconstruction. And so they have some recommendations. And they said that, again, that it is worthwhile to consider pelvic floor training. We look at evidence levels. There's kind of A, B, and C. And this is a level C. There's also some question about preoperative, and I think it's reasonable to discuss. And if you have the option to do that, I think knowing what you're going to do afterwards is somewhat helpful. So we'll also talk about penile clamps. I bring this up not that I think it's a great method of treatment, but it is something that I've seen patients be incontinent, wearing diapers for 10 years, 15 years, and have never heard of a clamp. So before we do surgery on anyone, I want them to know that this is there are simpler options that are out there. And if you don't want to have surgery, you can try it. So this is a Cunningham clamp. It just snips into place onto the, gently snips into place on the penis and allows control. When one needs to urinate, pinch the lever, opens up, and they're able to urinate, and they can replace it. And so not ideal, but it's a non-operative way to manage your incontinence. And there are things like this, things like condom catheters, other simple things that you can use to maintain control so you're not diffusely leaking. This is a system, get this through the VA. Pilots used to wear it, thought it was very interesting, very expensive. I think I had one patient use it again through the VA, but penis goes in the little male cup part, and there's a little suction that pull the urine out of there so it would not sit and keep you wet. But just there are those things that are out there that you can look for. And I will tell you that patients bring things to me, and I learn from patients all the time. So look out there and see what you can find. Okay, so again, surgical timing. So again, we went through this a little bit before, but again, the AUA, SUFU, strong recommendation level evidence that if it doesn't improve by the 12-month mark, start to consider some treatment, and we're gonna go through some of these treatment options. So bulking agents, I'll be quick on these. They are really not that helpful, but the idea here is you're injecting material into the sphincter to bulk up the sphincter to make it tighter, because you have to have a seal for you to stay dry. We use different agents. There's collagen, there's Durasvir, and coaptite. None of these are FDA approved for men. They are for women. I'll show you here just here's a little pictorial of doing it. So what you're seeing is this is the sphincter area right there in the center. In the back there is the bladder, and we're looking to try to bulk this area. You see where it's open, that needs to be sealed shut to create control. So you see the needle there at 5 o'clock. What we do is then we inject that under the epithelium of the sphincter area. And so we injected at the bottom there. You see you got rising up that area to the top. And then the next shot was just a complete closure, and that person was completely dry and worked well. The only difference is that was a female. Which I don't treat many females anymore, but that's an old side of doing a collagen injection, or that was actually a coaptite injection in a female. It does not work that well in men. And the reason is that that's an area of scarring where the prostate was removed and the bladder and the urethra are put together. That area is somewhat fixed and it's not mobile. So you inject these under the epithelium, it doesn't come together and close so that you get excellent closure like that. So when we look at these, there really is actually strong evidence against using bulking agents. When they do work, they work very short term. You oftentimes need to inject again. And I have seen some men, I get calls from urologists every once in a while saying, oh my gosh, I tried an injection and his incontinence got 5 times worse. Can you see him tomorrow? And so we use it, or urologists tend to use it in people who have very mild incontinence. You do it, and then if the incontinence gets worse, suddenly it's a problem. So not one that we use very often. The other thing I would say about it is there's some injectables like macroplastique is used as well. Again, a lot is off-label, but they make our reconstructive surgeries more challenging. So they are sometimes so bulky that our slings and sphincters don't work well, so it can become a little bit of an issue. All right, let's talk about PROACT. This is a newer device that's come out, and what this sort of cartoon shows here is you can see the bladder, and there's 2 balloons that are put through the perineum. They go up and they rest on either side of the sphincter, and you can adjust the volume of fluid in those balloons to create compression of the sphincter. And then you can either increase or decrease that volume postoperatively by these little injection ports that are right under the skin at that area. And it's new. I don't have any experience doing it. I'm interested in seeing how it works. There are those that are doing it throughout the country. I know of some who have done, and they've actually had injury to the urethra with doing it. So I think there is a level of experience that you need to have doing these. But I just mentioned that that's out there and an option. The overall dryness rate is about 60% with the PROACT in their data. The revisions are about 22%. Some were out in some other numbers up as high as 73% revision rate. So I would say it's something that you could look at, but the AUA didn't make any strong recommendation either way because they didn't have a lot of data at the time. This came out in 2019. They're reporting on incontinence. Let's talk about mild and moderate incontinence. Let's talk about the slings. This right here is kind of a list of all of the devices that are out there. It's kind of a laundry list. It's actually from 2014, but it gives you all of the different types that are not only available in the United States, but in other countries. And we only have really 4 of these that are available to us right now, which we're going to talk about. But this is what's out there and gives you kind of what their complication rates are and little particulars about each of those. But we'll talk about a few of these. So looking at the male sling, they are used for mild incontinence. They should be non-obstructing. They really are trying to just change the outlet with the sphincter works to try to help improve your control. So historically, the Invan sling was one that was used. We used screws put into bones just to show you what that looked like. There are 3 screws on either side. We just tied down the mesh onto the urethra to create that. Didn't work well long-term, and there were issues with those screws going into the bone and creating discomfort. So was not something that was long-lived. So what came out of the Invance was something called the Advance sling, which elevates the urethra. So the way that looks is right here. We do a small incision in the perineum. We place this mesh sling right onto the urethra. We take 2 small openings on either side of the scrotum, kind of the folds where the leg comes, and we then can adjust the tension of that sling to create the effect that we want. And again, this has been shown to be very effective in the right patient. So this is how it's placed, a little cartoon. You see the urethra there, and we have a little trocar. The mesh is a polypropylene mesh, so it's a permanent suture that's there. So if we get the effect, the hope is it works long-term. Now, the way the sling works is the body has to grow into the interstices of that sling. So it's like a chain link fence. And so as your body fixes into place, it can work well. So after the surgery for a sling, you have to take it easy for about 6 to 8 weeks. You're not doing any heavy lifting or squatting to loosen up the sling. And this shows you from the side the effect we're getting. So the top part of this picture shows from the side, you'll see the bladder to the left. There's the pubic bone there. The sling is in black, and then the urethra is in blue there. And as we tension the sling, or as we pull the sling up, you'll see that the bulb of the urethra sort of repositions up toward the bladder neck. And that's probably where we get the effect. You take a sphincter that should be circular and working in the right position. It's because the tension from the removal of the prostate now is sitting tangential, so it doesn't work well. When you take the sling and you put that back and reapproximate the sphincter in a normal position, well, now it's in a good circular motion. It can close better than if it's sitting tangential and doesn't close well. And that's the theory of how that would work. And so, again, this is the sling looking sort of from the side, and what you'll see, you'll have the bladder up here, and then this is the area of membranous urethra, the amount of the sphincter that's functional there before you tension. You notice what the size of that is, and then when we reposition that sling, or position the sling and reposition the sphincter, you'll see we have a much larger area of continence that gives you better closure. So that's the theory of how that sling would work and give you hopefully effective control. There are different slings that are out there. Just to give you idea, the Virtue is a quadratic sling, and that can work well. The Advance is just a 2-arm sling, and I think that works well. And Advance now has an Advance XP, which is a little bit better type of a mesh. The artificial urinary sphincter is a different type of procedure. This has, again, for those who have mild, moderate, or severe incontinence, you can choose them for either of these. It's probably our gold standard. It's been around longer than the slings and can be very effective and show maybe a better effectiveness than some of the slings when you look at some of the outcomes. But it's a little bit more of a device. So when you look, there's a pump that goes in the scrotum. This is all under the skin. You cannot see it. The only thing you really know or feel would be that pump, which is hidden under the scrotal skin. And the way this functions is when it's turned on, there's a salt solution that's in the system. It creates closure on the cuff, almost like a blood pressure cuff, except it's always turned on and creating closure, squeezing on the urethra so no urine comes out. So anatomically on this picture here, you can see the bladder. Urine should not get past that cuff until your bladder feels full. And when you feel full, you pump that pump, 2 to 3 pumps. That should pull the salt solution from the cuff down to the pump, put it back into the balloon. The balloon has a certain wall tension that will push the fluid back through the tubing to the pump, fill the pump up, and go down the cuff and close the cuff. And that takes probably about 60 to 90 seconds. So that's how long you'd have to urinate. If you need the longer, you can pump it again to keep it open. So the only time you have to pump this is when you need to urinate. And that's the artificial urinary sphincter. Kind of show you another view of how that would look. So when we have patients who have urinary incontinence, they come to see us as reconstructive urologists. First thing we do is we take a history and physical exam, try to rule out reversible causes, see if we can avoid doing surgery if possible. Again, educate you what's out there. Sometimes we'll do what's called a 24-hour pad weight. We don't always do that, but it's helpful to give us an idea of how much you leak. So what we do is have you take from 7 a.m. one day to 7 a.m. the next day. Every pad you use, you put in a Ziploc bag, you seal it, and then put every pad you use that day, and then bring that big Ziploc baggie in for us to weigh. We use the Ziploc so the urine doesn't evaporate, so we get a good number or a good volume of how much leaking you have, and then we use that to help quantify that and then put your risk categories for outcomes for sling versus artificial sphincter. And so if you have less than 200 cc's, sling is probably a reasonable option. If you have more than 400 cc's, an artificial sphincter is probably a better option. And then we have a discussion about your level of comfort of outcomes. For evaluation, we always do what's called a cystoscopy. It's a flexible cystoscope. We look into the urethra, into the bladder, see how things look. We're looking for multiple things. One is looking at how does your sphincter coaptate? So how it collapse well. Then we give you a grade. I have a grading scale of 0 to 5. 0 doesn't do well at all. 5 looks perfect. There's certain how long it is, how tight it gets, how active it is. So it's a bit of subjective grading. We try to figure out how good does that sphincter work. And we're looking for other things like scar tissue, contractures, foreign bodies. We've actually found things that are stuck in from the repair, and those things you want to identify before we do any procedures. We also do a bedside urodynamics where you cough and see how much you leak, usually while you're laying. Then we sit you up, and then we stand you up and just see what makes you leak. And again, we get a bit of a feel for how severe the incontinence is. So if we look in there on cystoscopy, we see there's a big defect, there's scarring of the sphincter, we know that that's, you're going to have issues, and a sling would less likely be effective. This little video that hopefully will work for us here. I'm going to try to play this. So you see how that squeezed well, and there's a good length to that. That was a good, I probably give that a 4 out of 5 or 5 out of 5 in terms of the grading. Now here's somebody who is not as good. So you can see that's a very different closure of that sphincter than the first one. There's not the length to it. There's not the severe closure, and that person had more severe incontinence. So again, that helps us to predict outcomes. This is, again, on cystoscopy, we found this calcification in this person's bladder neck. So we said, we want to take you to the operating first, get that out of there, see what's going on. And we found it was one of the clips they used during the prostate surgery. And that does happen sometimes. That clip may migrate. It sat right in the bladder neck where the anastomosis was. And so sometimes if you take those clips out, that may allow the bladder neck to close better and give you better continence. So it's something that we would at least look at to make sure before you go and do some other surgery that you may not need if that were to work well for us. So that's how that would look. And then, so now there's some other grading systems just looking at, and I'll kind of, not to go through too much detail, but if you look and, again, fill a bladder with fluid on cystoscopy, then we do our stress maneuvers, do our bedside urodynamics, you can predict the outcomes based on a recent study that Amar did in Texas. If you take that cough test that we did and say they used a grading scale of 0 to 5 or 0 to 4, 5 areas to look at. So no leakage, delayed drops only, early drops, no stream, early drops, delayed stream, or just stand up and leak completely, found different outcomes. And these are the outcomes. And so what we found is that if you had no leakage or minimal leakage, that they had good outcomes of 78% with the sling. If you had more significant leakage, we've got in the yellow there, that your outcomes were much better for the artificial inner sphincter. And so they would more strongly at least advise a patient to look at the artificial sphincter as a better treatment, but ultimately the patient makes a choice. We just try to give you information so you come up with what you'd like to ultimately do. And then just a word on urodynamics. I used to do urodynamics on most patients, and now it's rare to do that. So urodynamics is kind of like an EKG of the bladder, where you come in, we put catheter in the bladder, fill the bladder up, and see how your bladder functions. How does it hold urine? Does it have spasms? Does the sphincter work well? And we can get a number called leak point pressure. But I found that never really made much difference in terms of our outcomes and recommendations. So the only people we do urodynamics on now are those who have neurologic issues, or if they're leaking at night. So most men who have post-prostatectomy incontinence, they're laying down at night, they are completely dry. They stand up or cough or sneeze, they leak. So if someone has some history that doesn't sound right, then we would consider a urodynamics. But I would say that's not a standard that we do for every patient at this point. Okay, so who's an ideal sling candidate? You have incontinence, and you really want to have a sling. Because I don't want anything, I got a pump. I just want to have the sling. So I would say, look, if you have less than 200 cc's per day, probably reasonable. If you have a good looking sphincter on cystoscopy, if you've got no injury to the sphincter, if you had no prior surgery, no prior bulking agents, some of the bulking agents have been shown to decrease outcomes in the sling. Radiation therapy decreases your outcomes. And again, if it's a radical prostatectomy over things like a TURP or other types of surgeries, they tend to do better. And knowing that the success rates are probably 70 to 80%, maybe up to 85% in some studies, but I would say 70 to 80% is what most urologists would quote. And again, frustrating for us, we do the same surgery in 2 different people. I've done it before. I've done the sling and 2 men back to back. They looked exactly the same. I did it while I was teaching. One guy came back and hugged me. He was happy. He was completely dry. The other person said it really didn't change much. And frustrating for us is we don't completely understand why it works well in one than the other. But That's just the nature of where we are right now with our understanding of how slings work and our outcomes. So I would say 78 to 80, maybe 85% success rates with a sling. So who's a poor sling candidate? Therefore, who should have the artificial urinary sphincter? Well, someone has more significant volume of incontinence. So if your volume is greater than 400 cc's leaking, probably a sling is less likely to be effective. I tell people probably less than 50%. If you have any of the other risk factors that we mentioned before, then you're probably a better candidate for an artificial urinary sphincter, but you're also a good candidate if you have very mild incontinence and you want something that's very effective. Our success rates are probably 80 to 90% with the artificial urinary sphincter. And so just for comparison, side by side, the artificial sphincter versus sling, they're both outpatient surgeries. Usually keep a catheter overnight. The artificial sphincter will require you to pump to urinate. Most men don't find that to be an issue. They're happy with it, but it does require hand manipulation. We do what's called delayed activation of the artificial sphincter. So it's turned off for about 8 weeks after the procedure. We allow the urethra to heal. And then we have better outcome, lower erosion rates. And so you don't get immediate effect. Whereas with the sling, we take the catheter out. You find out right away if you are dry or not. There is somewhat of a retention rate with slings, which we don't tend to see with sphincters. So about 10 to 15% of men after a male sling have urinary retention, which is we got to put a catheter back in. We just usually wait for a week to 10 days. I've never had anybody stay in retention or had to remove the sling for that reason. So it's usually very temporary. Both you can have an MRI, and I would say the only warning with the artificial sphincter is you have to be very, very careful about having a catheter placed in the future after you've had a sling in position. We usually would say, I tell my patients come to our office, if you're going to have, say, back surgery, come to our office the day beforehand, we will deactivate your sphincter, and we'll put a 14 French or smaller catheter in so nobody else has any effect of that. And again, our success rates in the sphincter are about 80 to 90%, and with a sling about 70 to 80%. I will say this is some of the things we've actually done for our patients here in Central Florida. We did have a temporary tattoo that we had patients use. You'd be surprised, patients who go to the operating room and tell, for knee surgery and say, I'm going to have surgery on my knee, but I have a catheter. You can't put a catheter in because I have an artificial sphincter, and they still have a catheter put in. And so we've had people put this as a tattoo in certain areas where they can at least let everybody know that they cannot have a catheter placed. And in our hospital system, once we place a sphincter, we have this as part of their electronic medical record. So they show up in the hospital with a stroke. In our system, this will fire. It says they have an artificial sphincter and cannot have a catheter placed. Again, to try to keep patients and the artificial urinary sphincter safe. So our treatment outcomes, again, observation is an option. You're not getting any better, but you're not going to have get any worse, but you won't have much of a change. The bulking agents, some people say as high as 25%. I'd say that's an overestimation. We really don't recommend that strongly. The slings are reasonable with 70 to maybe up to 85% success rates, and the artificial sphincter is really in the 80 to 90% range of effectiveness. So yeah, I think those are all reasonable options for treatment. And again, wherever you are, find a urologist. There's those in the Sexual Medicine Society who are very skilled at doing this. You can find them online if you go into fixed incontinence. If you just Google that, you'll find urologists do a fair amount of this. And again, these are minimally invasive treatments, usually outpatient, high satisfaction rates. And if anything goes wrong, like with a sphincter, patients at our office saying the next day, we can replace the sphincter right away. They love them. To me, it's the most gratifying thing that I do. And I'll continue doing this probably for the rest of my career. So I'll end that with there. And then, Mark, we can kind of go over some questions if you've had.